Good evening, everyone. Welcome to our virtual family council. My name is Jamie Rose. I'm your virtual family council coordinator. We're going to review our confidentiality statement at this time. Please refrain from using the name of your loved one. Do not name specific facilities. Please use a nursing home or the personal care home to present to the group. If you need specific assistance, please use the chat feature to state which county you're in, and we will get you connected to your assigned ombudsman. And these calls have public access and are designed for family members and friends of residents in long-term care facilities. In tonight's meeting agenda, we're going to get our virtual tips from Eliza, and then we're going to get a presentation on residents' rights by the National Consumer Voice, and then we'll review our upcoming meeting topics. Without further ado, I'll turn it over to Eliza for our meeting tips.
Hi, everyone. My name is Eliza, and I'll be giving you your tips for this evening. You all have been placed in mute upon entry. We will open the lines in a bit so that you're all able to share. If you would like to speak or if you have a question, if you could please use the raise hand feature. Once you raise your hand, we will acknowledge you and unmute your line. If you hover over your mouse near the bottom of the screen, you'll see the participants tab. You can expand that tab if you'd like to see who all is in the chat with us tonight. The chat feature is at the bottom of your screen as well. Once you maximize it, you'll be able to send questions to the chat moderator or to others during the call. Closed captioning is also available during the call. To enable that feature, just push the CC icon at the bottom of your screen and choose to enable closed captioning. If you need to step away for any reason, you can stop sharing your camera icon by clicking on that icon at the bottom of your screen. You can then click on it again when you come back to the computer and you want to start sharing your camera again. Any concerns or complaints can be directed to the State Long-Term Care Ombudsman Office at 717-783-8975 or by email at ltc-ombudsman@pa.gov.
And at this time, I'd like to welcome Robyn Grant and Jocelyn Bogdan from the National Consumer Voice. Welcome, ladies.
Thank you. It's great to be here. So on behalf of the National Consumer Voice for Quality Long-Term Care, and we're just going to go by Consumer Voice for short because that name is way too long, but we're just delighted to have this opportunity to talk with you tonight about nursing home residents' rights. And I do know that some of you have loved ones in assisted living or personal care homes, but tonight's presentation will focus on nursing home residents' rights because rights are different in assisted living. So at some point, hopefully you'll be able to cover those as well. But again, I'm Robyn Grant. I'm the Director of Public Policy and Advocacy, and with me is Jocelyn Bogdan, who's the Program and Policy Specialist. So since the COVID crisis began, I think it is felt in many ways like residents' rights have kind of gone out the window and have been ignored. So I think the bad news is that in many ways, a lot of rights have been disregarded. But the good news is that they haven't gone away. And with just a few exceptions, residents' rights are all still in effect and should be honored and respected. So in the time that we have, we'd like to discuss a number of key rights. We obviously can't cover all the rights because luckily there are lots of them, but we want to highlight a few, as well as hearing from all of you about what you're seeing and experiencing in your loved ones' facilities in terms of visitation and resident life. So Jocelyn and I are kind of going to go back and forth. We're going to tag team. Let's get started, and I'm going to get us going here. So next slide, please. So care and services, one of the most important and really overarching rights is that residents have the right to receive care and services to obtain their highest level of well-being. So what does that mean? It means that the nursing home has to provide whatever care, treatment, services are necessary for each resident to reach their highest level, and here's the actual language, of physical, mental, and psychosocial well-being. So they're to reach their highest possible level or maintain their current level of well-being, but they must not get worse or decline unless they have a medical condition that is progressing or they refuse treatment. So in other words, and lots of people, we don't think like this often, but it is illegal for nursing homes to make residents worse unless there is, as I said, a medical condition or they refuse treatment. So residents should not be experiencing avoidable declines. So this is about individualized, person-centered care for each resident. And the language is specifically each resident. So that means that it's not one size fits all. The needs of one resident are different from the needs of someone else. And that needs to be taken into consideration, and the care and services that one resident receives should not be identical to those that another resident needs because they are not identical individuals. So this right is about both quality of care and quality of life. And actually, in the eyes of the law, quality of life is just as important as quality of care. So Jocelyn is now going to talk with you a little bit about care planning.
Perfect. And the slide moved. Hi, I'm Jocelyn Bogdan. So the right to care planning. So what Robyn was just talking about, achieving this high level of care, one way to ensure that residents are receiving the highest level of care they can is through care planning. And a care plan is a strategy for how the staff is going to help ensure that residents' needs are met. Residents have the right to participate in the development, the implementation of a person-centered, and I think you're going to hear that language a lot tonight, of a person-centered plan of care that focuses on their individual needs. They have the right to participate in their own assessment, to make decisions about their care both now and in the future, and residents have the right to request care planning meetings if they feel they need them. And so in practice, this means that residents have the right to make choices about their care, services, their daily schedules, and their life within the facility, and they get to be involved in their care planning meeting. So a few things that go along with this are the right to receive adequate and appropriate care, to be informed of all changes in their medical condition, to refuse medication and treatment, and to refuse chemical and physical restraints, which we're going to talk about a little more in a few minutes. With COVID, the need for individualized care has really increased. It's really important that residents and their family assert this right and ask for care planning conferences if needed. This care planning conference is a time and place to bring up problems, to ask questions, and to get more information from the staff. And so one way this is extra important right now is in regards to visitation, which we'll talk about that more a little bit later, but something that continues to be true about visitation, even now that it's more limited, is that it also needs to be person-centered based on the resident's needs. So if a resident needs more visitation than they're receiving, this might be a good time to ask for a care planning conference to discuss it and try to get that written into their care plan. So that is just an example of how, and what you can do in these meetings. And I'm gonna flip it back over to Robyn.
Okay, so the next right we want to cover is the right to be free from abuse, neglect, exploitation, and misappropriation of property. And when we talk about misappropriation of resident property, that includes stealing resident personal funds, for example, and their possessions as well. So the nursing home has a duty and an obligation to keep residents free from abuse, neglect, exploitation, and misappropriation of their property. And to do that, facilities are required to take a number of very specific steps. And you can see what those steps are on the slide. So to begin with, a facility has to have policies and procedures that prohibit and prevent abuse and neglect and misappropriation and exploitation. And I tell you what, from now on, I think I'm just going to say abuse, because otherwise it's a mouthful. But know that when I'm saying abuse, I also mean neglect, exploitation, and misappropriation of resident property. But a facility has to have policies about abuse and preventing abuse and neglect. And part of those policies, one thing that must be included is that staff have to be screened prior to being hired. Now, federal requirements don't call for or mandate a national comprehensive background check. I don't know what your requirements are in Pennsylvania. Maybe we can cover that later for any kind of background check. But at a minimum, I mean, facilities have to do things like if they're hiring a nurse aide, they have to check the state nurse aide registry to see if there have been any findings against a nurse aide. And if there are, then they can't hire that individual. They have to check to see if there have been any convictions for abuse and neglect against that person. And they have to check if an individual is a licensed healthcare professional, like a licensed nurse. They have to check the state licensing board to see if there have been any disciplinary actions. So there are some checks, but they don't have to, for example, do a national to find out if perhaps an aide is on a registry in another state. So they have to be screened. Staff have to be trained on how to prevent and report abuse. And that training piece has to be part of a training program for new and existing staff. And in addition, nurse aides, as part of their in-service training that they're required to have every year, have to be trained on resident abuse prevention. So a high expectation about training there. Staff have to be trained also not only on how to prevent abuse, but what the reporting requirements are. So to dig just a little bit into that, when abuse is suspected, so not just when you can tell that it's actually happened, but if you think it's happened, it has to be reported to the facility administrator, but also to the state survey agency. And if you have an adult protective service agency that covers nursing homes, then to them as well. And it has to be investigated by the facility. So they have to report it right away. And then the facility has to conduct its own investigation. While they're doing that investigation, they have to make sure that the abuse doesn't continue and that no other residents, are harmed. Once facilities have to do that investigation within 5 days, and then they have to report back to the state survey agency what the findings are. And depending on what the findings are, then they have to take corrective action. So there are a lot of steps that are required for this. And if it's suspected that there's been a crime, the facility also has to report to law enforcement, so the police as well. So one thing I want to say about resident property and the misappropriation is that facilities cannot require a resident or someone or their representative to sign a waiver that says the facility is not responsible for lost property. We have seen that a lot, certainly in the past. This regulation went into effect in 2016. And the idea is that facilities cannot escape their responsibility for overseeing and caring for a resident's property. So they can't just say, we don't have any responsibility. So make sure to check your the contract, the admission agreement that you signed, to make sure there isn't a provision that waives their responsibility. And certainly if you ever, I hope that never happens, but if you are facing a situation where there has been loss or theft of their property and they say they're not responsible, remember that that is not the case and they are indeed responsible. So detailed and specific requirements around abuse and neglect, because this is such a serious issue and residents are so dependent and frail in many cases. So there's also the right to be free from chemical restraints, which Jocelyn is going to tell you a little bit about now.
Thanks. So all residents have the right to be free from physical and chemical restraints. And we really want to emphasize the right to be free from chemical restraints today because, while it's always important, it's really taken on increased importance this past year during COVID. Residents have the right to say no to medication. That, I think, is the most important takeaway. And there are certain medications, antipsychotic drugs, that are sometimes prescribed not to treat a medical diagnosis, but instead they're given to residents off-label to control the resident's actions, or the facility will call it the resident's behavior. They're also given, one way we look at it is for staff convenience. And this is considered a chemical restraint. When these drugs are given off-label, they pose huge risks, particularly for residents with dementia. They come with black box warnings, which is the highest warning that drugs have. And one of the side effects could be death. These drugs are very dangerous. During the pandemic, we know there has been a big increase in antipsychotic drugs being prescribed, which is very unfortunate, but sadly, it's not terribly surprising as facilities were short-staffed and families weren't able to come in. And this was a side effect we were worried about, and now we've started to see the data that it has happened. Equally disturbing, we saw a big increase in the months immediately after the pandemic began and facilities shut down of residents being diagnosed with schizophrenia. Now, schizophrenia is a condition that's almost always diagnosed in your late teens or in your 20s. You don't develop schizophrenia at 85. That said, if a resident has schizophrenia, it might make sense for them to be prescribed certain antipsychotics. So this is a way that certain medications can be prescribed to people so that it's not off-label, but it's now for a specific diagnosis. It's just very unclear how anyone would suddenly become schizophrenic at that age. And I think the number of residents who somehow developed schizophrenia in April, May, and June of 2020 was around 7,000. That's huge, and that's a lot of people being given these drugs. We've heard from several family members who only heard afterwards that their loved one's medications changed, that they'd been put on new medications that they're not aware of. This always happens, so this is not specifically a COVID problem, but with people being shut out of facilities and with the short staffing, this happened a lot more over the past year. And so with everything else we've talked about, with the right to receive quality, person-centered, individualized care and being involved in your own care planning and making your own choices and treatment decisions, it's really important to remember that residents have that right to decline this medicine and say no to these drugs. And so if you have a family member who's struggling and a facility that comes to you wanting to prescribe off-label medication, there are questions you can ask, suggestions you can raise. You can emphasize that the facility needs to identify and address the cause of your loved one's behavioral symptoms. If they're maybe hungry or cold or in pain, a lot of people are in pain and it's gone undetected. And I think, again, over the past year, when people were short-staffed and certain things weren't able to be taken care of, I saw someone just write in the chat that their mother's oral hygiene, they weren't able to see it because of the mask, but that it went completely untreated. So when people end up in pain, people with dementia, they might behave, they might call out, scream, or just act like they're disturbed or in distress. And the response should not be to prescribe these drugs. There are many reasons that residents could be distressed, and there are many different ways to address their distress that don't include these medications. There could be an outside environmental trigger. It could be lights, it could be noise, it could be a new roommate, it could be certain smells. But it's important to emphasize that facilities need to address the underlying cause of what the resident is experiencing. And it's important for family members, if you're acting as a resident representative, and for residents themselves to understand that they have the right to say no to these drugs and to ask for the person-centered care that they deserve. And so I'm going to turn this back over to Robyn.
Thank you. So I want to talk about grievances. So as you can imagine, residents can have concerns about any number of issues. It could be the timeliness of the care. It could be the care that they're supposed to get but aren't, how they're treated, the food, a whole range of issues are things that residents could have concerns about. So when a resident does have a complaint, they have the right to file a grievance with the facility without retaliation or even the fear of retaliation. And then the facility is required to work to resolve those complaints promptly. Now, there isn't really a definition of promptly, but generally it's informally, I have to say, considered to be around 10 days, but that's not set in stone, and each facility, it will be different in every facility. But each facility has to have a grievance policy that explains the process for filing a complaint, and you can certainly do that on behalf of your loved one. So for filing the complaint, looking into the complaint, and resolving it. And that policy has to be provided to residents and the representatives upon request. We really wish that were a requirement that said it just has to be provided upon admission and maybe annually thereafter, but it does say upon request. So one of the things I really recommend that you do is ask for a copy of the grievance policy, because it's usually, I think it's better to get it when you're not about to file a complaint, but just as something so that you're informed and so you have it. But you do have to make that request. So residents or on their behalf can file grievances in writing, orally, or even anonymously with the facility. I will say that I think it's advisable to file it in writing. First of all, because you can put details in it and you can make sure that those details are conveyed the way you want them to be. You know what happens when you say something to somebody orally. It may not always kind of come out the way you wanted it to be, and it's not as precise or as accurate as if you put something in writing. However, it does not have to be in writing. Thing about writing is that you'll have a record of it, and that is extremely helpful as well. But complaints go to a specific staff person who's called the grievance official, and that person is responsible for complaint handling. That person oversees everything then, the whole grievance process. So that could range from receiving the complaint, tracking it, investigating it, making sure the information is kept confidential, and then also making sure that a resident gets a written decision about the findings of the complaint investigation. Now, I want to point out that the grievance official doesn't have to be the one that does every single aspect of the complaint handling process, but they are responsible for making sure that all the steps are taken and for making sure that the process from the beginning to the end is followed. So residents have to be told how long the process will take. So as I said earlier, the regs refer to kind of prompt efforts to resolve a complaint, and they also talk about a reasonable time frame. So again, it's not defined at all in the regulation. Perhaps maybe in Pennsylvania, if you have state-specific rights, it might. Some states, they actually define what that time frame is, but the federal requirements, and that's what we're talking about now, don't define it. As I said, most people tend to think that it's about 10 days, to 2 weeks, but the facility has to tell you what that time frame is, for your loved one in your loved one's facility. So at the conclusion of the investigation, the resident has to be given a written decision. And that includes information about what was done to investigate the complaint, what the findings were, whether the complaint was confirmed, and then any action that the facility has taken or will take to correct the problem. I continue to be very excited about the fact that there is a written decision, because prior to the change in regulations, filing a complaint was very often just like throwing something into a black hole. Families, residents often never heard anything back about their complaint. So at least here, you are required to be given the decision in writing. So I think that that can be very helpful. So that's the internal process for filing a complaint within the facility, but there are other places outside the facility where you can turn if you have a concern or grievance, and Jocelyn's going to tell you a little bit about that.
Sure. And so I feel a little bit like I'm preaching to the choir here, because I know that most of you probably are very familiar with your Ombudsman program, but it's still an important thing to just go over. So residents have the right to access their long-term care ombudsman program. And I'll just throw out that that has remained true throughout the pandemic, despite the fact that for a long time, I know ombudsmen weren't physically able to enter facilities in most places, but they still had the right to have that access, whether it was over the phone or virtually. Every state is required to have an ombudsman program under the Older Americans Act, and ombudsmen are, as I'm sure you all know, advocates for residents. They provide support. They help address concerns. And so at Consumer Voice, when a resident or family member calls us with an issue that's specific to their facility, the first thing we tell them is almost always to reach out to their local ombudsman program. We give them that information so that the ombudsman can help them advocate with the facilities. And we know now that in many states, and I don't know specifically in Pennsylvania when this shifted or to what extent, but ombudsmen are typically now back inside facilities, which I think is enormously important, because before, while that access always existed, we know for many residents, it was really hard to access the program. With ombudsmen able to enter the facilities and physically be there and have eyes on what's happening in the facility, it's just very helpful for everyone. But in addition to working with your ombudsman if you have a problem or an issue, there's also the state survey agency, and residents can file complaints with the state survey agency. So can family members, and in fact, so can staff. If a resident is being denied their rights, or if they have specific concerns about their quality of care, or if you as a family member have concerns about their quality of care, you can file a complaint with the state survey agency, who should then investigate that complaint. I mentioned a staff member because I think a lot of people think that, filing complaints is very specific to an individual resident, but we had someone call us recently who was a CNA at a facility where, some pretty egregious things happened, and, he was sort of like being a whistleblower calling us. And so the first thing I said to him was file a complaint with the state survey agency, tell them what happened. Because, as Robyn was just talking about with the grievance process being written and having something written, we often tell people to file these complaints, even during the pandemic when very little was actually being investigated, because you want this in writing. It's important to have it in writing. And so I just looked up And these numbers don't mean that much to me. They might mean more to you. What it looks like right now in Pennsylvania, I saw that the Pennsylvania Department of Health said that for April 2021, nursing home surveyors conducted 427 inspections, and 281 of those were complaint investigations at 307 separate nursing homes. And 90 were specifically related to COVID, which could mean a lot of different things. But it resulted in $37,000 worth of fines to nursing homes. So that's one thing that can happen when you file a complaint. There can be a civil monetary penalty held against the facility. And so again, I mean, I don't know how many complaints were filed in Pennsylvania. I do know that many people don't always feel comfortable or don't know that that's an option they really have. A lot of people, without really being told, don't turn to the state survey agency. But if something happens that is wrong, that something isn't right, if you're not getting anywhere else with the facility, it is really important to file that complaint and put it on record, because it'll maybe hopefully will get investigated, but it also helps build that record about what's happening. And so there's a link on this slide and I'm sure you guys already have this information, but that should connect you to the specific information for Pennsylvania, where you can find the local Ombudsman Program and information for your state survey agency. So I will turn it back to Robyn.
Okay. So I want to talk a little bit about rights related to transfers or discharges. Unfortunately, far too often, residents are told that they have to leave the facility and they aren't given any notice or any information about their rights. So we certainly hope that your loved ones are never in this position. But if this were to happen, we want to make sure that you know what those rights are. So first of all, the resident has the right to remain in the facility and not be transferred or discharged out of the facility when the resident doesn't want to leave. There are only 6 permissible reasons that a facility can discharge a resident. So if the facility proposes to discharge someone, it can only be for one of these reasons. So I just want to cover them very briefly. If the facility can't meet the resident's needs, if the resident has improved and doesn't need nursing home care, that's the happy reason, right, to leave the facility. The resident is endangering the safety of others. The resident is endangering the health of others, non-payment, and if the facility is closing. Thankfully, that last one doesn't happen very often, but that obviously is a reason for transferring or discharging residents. So in addition to the fact that there are only certain reasons that a facility can discharge or transfer someone, there are also some procedural protections for the resident as well. And one of those is that the resident has to be given advance written notice, and that's usually 30 days prior to the date of the proposed transfer or discharge. There are a few exceptions to that, but that written notice is extremely important because it gives the reason for the transfer. It says where the resident is going. I'm supposed to say that. It provides information about how to contact your local ombudsman, and it gives you information about how you can file an appeal, which is the second procedural protection that I want to highlight. This is extremely important because as a resident, you don't have to just accept that that's what the facility is going to do. You have the right to challenge that proposed transfer or discharge by appealing it. And then there is, if you do appeal that, there is a hearing that's held. Usually that's held in front of an administrative law judge, and the burden is on the facility to prove that it has the right to transfer or discharge the resident, but the resident has the opportunity to make his or her case and to have somebody there or more than one person, but to represent them, to help them in fighting and arguing for why the resident should be permitted to stay. So I don't know how the process works in Pennsylvania, but in that person who represents a resident could be an attorney, but it also could be, it could actually be anybody. And in a number of states, it is actually the ombudsman who represents the resident. And I will say that ombudsmen are often very successful in winning these cases. But the important thing to remember is you have the right to appeal. So that is information about transfers and discharges from the facility. I wanted to touch just very, very briefly on with moves or transfers within the facility. There are some very limited restrictions on what can happen in terms of moving a resident within the nursing home. But one of them that I wanted to highlight for you is that a resident can actually refuse to be moved from one room to another within the facility if the reason for that transfer is just for the convenience of staff. So let me give you an example. A resident is in a specific room and her condition worsens. She needs more care than she had in the past. And what the facility does, because it's easier for staff, is they like to group the residents that need more care together in maybe a certain wing or a certain part of a hall, so that they have everybody together. So that is solely for the convenience of staff. So a resident can say, no, I'm going to refuse that. And they'd have the right to stay in their room, not be transferred, and get the care that they need where they are. So that's just an example of one right that they have related to transfers within the facility. Next slide, please. So during the pandemic, the federal government, the Centers for Medicare and Medicaid Services, waived some of the discharge, transfer discharge requirements that I just covered. So at this point, you don't have to worry about any of that. All the waivers have been ended except for one, and that has to do with the reason for the transfer or discharge. So you'll remember that I said there are only 6 permissible reasons. Well, actually, during the pandemic and lasting even and now, there's a 7th reason. So nursing homes are allowed to transfer or discharge a resident or change a resident's room within the facility for one other reason, and that's for the purposes of cohorting. So that's a term by now you've probably heard, but that's the practice of grouping residents together so that those with COVID are separated from those without COVID. And it's an established public health safety measure to cohort. So nursing homes still have to give advance notice, but for cohorting reasons only, they can transfer or discharge a resident out of the facility to a COVID-only nursing home. They can transfer or discharge a resident to a home that is COVID negative, or they can move a resident from one room, one unit, whatever, to another within the facility because they have a COVID unit or part of a unit or a hallway, something like that. So the takeaway message here is that all the transfer discharge protections are still in effect, but the only change is that moves and discharges can also be done to cohort residents. So that will probably last for the duration of the public health emergency. We don't know how long that will be, but the key thing here is to remember that all the transfer discharge protections are still in effect. So Jocelyn, I'm going to turn it over to you to talk about visitation. Big issue.
Yeah, so I think everyone on this call knows that visitation is one of the rights that was hugely impacted by the pandemic. You would have to be living in a hole somewhere on another planet to not realize that. So to start with, before March 2020, residents had the right to have the visitors they wanted when they wanted them, subject to very, very few, if any, limitations. So we saw once the pandemic started, a visitation ban went into effect through CMS guidance. And then slowly, that ban lifted in limited ways, again through guidance, as the pandemic went on. So things opened up a little bit in September of 2020, and then a bit more recently in March of 2021. And we're now at the point where CMS has said that facilities should allow indoor visitation at all times for all residents, with a few narrow exceptions. And those exceptions, which you may be well acquainted with already, are if a resident is unvaccinated and the county positivity rate is over 10% and the vaccination rate in the facility is under 70%. It's if the resident has a confirmed case of COVID-19, if the resident is in quarantine, or if the facility is shut down because of an outbreak. Now, even in those exceptions, two types of visitation continue. Compassionate care visitation, which occurs when the resident is experiencing a physical or emotional decline or experiencing distress, as well as visitation that's allowed under federal disability rights law. Okay, the guidance also says that nursing homes must facilitate in-person visitation unless there's an adequate reason related to clinical necessity or resident safety. And they emphasize that visitation, again, needs to be person-centered, and this is really important. But despite all of that, the guidance also allows facilities an enormous amount of discretion. It says that facilities should consider the number of visitors per resident at any one time and the total number of visitors in the building at any one time in terms of COVID infection prevention protocols like social distancing. So we don't want to overcrowd buildings. And they say that facilities should consider scheduling visits for specific lengths of time to ensure that everyone can have visitors. And it also says that if residents have a roommate, it's preferable not to have visitation in the resident's room if it can be avoided, unless that resident can't have visitation elsewhere for some physical reason. And so the question really is, what is a resident's right to visitation now in June 2021, 15 months after the pandemic started? And I think it varies, but Consumer Voice started a survey of residents a month ago, asking them about what life is like inside their facilities right now. And I'm going to share some of what we learned from residents themselves with regards to what visitation looks like. And this was national, so this is not specific to Pennsylvania. But later, as Robyn said earlier, we want to open this up a bit to ask what you are hearing. To start with, we had 133 residents who responded to our survey in the past few weeks, which we thought was great. And of them, 85% are able to have indoor visits with friends and family, which is certainly a huge improvement from where we were a few months ago, even probably a few weeks ago in some places. But 72% of those residents are saying that their visits are limited in length to anywhere between 15 minutes and 2 hours. And a lot of the comments were saying that the visits are 30 to 40 minutes. 50% of the people who were the residents who responded are also reporting that their visits are limited in frequency. Now, that number, 50%, has actually gone down since the survey started. So it started higher, and now as more people respond, and maybe as time moves forward, less people are reporting that limited in frequency, but it's still half, 50% of people. And they're saying anywhere from 1 to 3 times a week that they're allowed to have visits. Most seem to suggest it's once or twice a week. Someone actually reported that they can only have a visitor once every 2 weeks. Many people are saying that their visits have to be scheduled in advance and can only be from 10 a.m. to 6 p.m. Or someone said visitation is only Mondays through Fridays until 3 p.m., which means working family members aren't going to really be able to visit. Someone said the visitation hours were from 9 to 11 and then from 2 to 5. And one person wrote that because the visitation was limited to working hours, her daughter can't come see her. Someone said that visitation can happen daily, but only if you've qualified for compassionate care. And then 79% of the people who responded said that they're limited in the number of visitors that they can have at any one time. Some people said children are not allowed to visit, children as in young children, not their children, but grandchildren, people under a certain age. And most people are saying that they can have 2 visitors at any one time. And so for families that are struggling with these limitations, something that we're telling people to remember is what the guidance says, that facilities should consider the number of people in the facility at any one time in terms of how it relates to infection prevention protocols. So it doesn't say that facilities can arbitrarily limit visitation to working hours. There's nothing in the guidance that suggests that. And so if that's happening, you need to ask the facility what their reasons are, reach out to the Ombudsman Program, because it shouldn't be happening. If you have a loved one with dementia and you're limited to a 30-minute visit twice a week, that's probably not sufficient for them. It's not enough time for them to adjust to what's happening. So that means that visitation isn't person-centered, and it is supposed to be. So you need to tell the facility that. Tell them they're required to have person-centered visitation and ask for that care planning conference. So this is where we kind of see how a lot of these rights come together and why it's so important to understand what your rights are. And so while we're seeing huge improvements from where we were a year ago, we are still clearly a very long way from a full restoration of what a resident's right to visitation was in February of 2020. 2-hour-long visits a week probably bring a lot of joy and relief to many residents and their families after this year. But for families that are used to helping their loved ones, helping them with eating or hygiene, or for the person on this call who was, writing in the chat about your mom's oral care, visiting once a week outside of their room is probably not going to get at the kind of visitation that is necessary for people. So we still have a really long way to go. And so I'm going to turn this over to Robyn to talk a little bit about residents' rights to self-determination.
Thank you. I think the ability to make choices and to have control over our lives is extremely important to all of us. And it is no less important to nursing home residents. I think you could argue in many ways that it may be even more important to nursing home residents. There are actually some very good and very strong residents' rights about being able to choose. Unfortunately, these rights, I think, are not very well known, and we are a long way from seeing them really implemented in a meaningful way in most nursing homes. So we just want to make sure that you're aware of them so you can advocate for them to become reality in your loved one's homes. On the slide, you can see what those rights are. The right to choose activities, schedules, healthcare, and providers consistent with the resident's interests, assessments, and plan of care. So what this means, in short, is that the resident should be able to live their lives as much as possible as they did before entering the nursing home. So for instance, if a resident likes to sleep until mid-morning, go outside for a walk in the middle of the afternoon, the facility should do whatever it can to make that happen for her. Why is that important? I was just thinking about this myself today and thinking about when I stay at someone else's house while it's nice, after a while I start to miss my own routine for a while. It's a nice change and I enjoy it, but I wouldn't want to have to live following somebody else's routine for the rest of my life. But that's what it can feel like for residents, being forced to live with a routine that is not of your choice or of your preference and not something you've been used to all your life. So I think that's an extremely important right. There are two other rights that have to do specifically with choosing aspects of life in the facility that are significant to residents, and the right to receive reasonable accommodation of needs and preferences. Both of those, along with the one I talked about first, kind of all go together. And the intent is that instead of life in the facility being organized and operating around the facility schedule and what works best for the facility, it's supposed to be the other way around. It's not the resident that has to adapt to the facility, but the facility must adapt to the resident. We are not there yet, which is why you may be thinking like, well, that's, we've never seen that. But the point is, those are the rights, and we need to keep pushing to make this a reality. So the last two rights, to interact with members of the community, participate in community activities, and to participate in a range of activities, both inside the facility and outside the facility, are all about the facility supporting and accommodating as much as possible of residents' needs and choices. So for example, if a resident wants to go to a community event, wants to go to a family gathering, the facility has to do what it can, again, to accommodate the residents' wishes to the greatest extent possible. And again, the idea is that the residents should be able to live their life as much as possible the way they've always lived it. To be able to spend their days, spend their time doing the things that they enjoy and that are important to them. So during the pandemic, sadly, that pretty much disappeared. I would say that there had been some progress before the pandemic, long way from where we needed to be, but still there had been some progress, but I think we have lost a lot during the pandemic, and there's certainly a lot less choice now than ever before. In fact, residents, a number of residents are saying, quite frankly, that they feel like they're in prison. The survey that Jocelyn talked about also asked questions about residents' daily life in the facility, in addition to visitation. And we heard things like there are many residents that are still confined to their rooms. Residents who are not able to eat with their friends in the dining room. Residents who are not able to participate in group activities. So you should know that that is not what the CMS guidance says. CMS does say that residents can eat in the dining room, they can do group activities in line with CDC guidance, which is that if all the residents are vaccinated, they don't have to wear masks or social distance. And if non-vaccinated residents are present, they can still eat together, still do group activities, but everyone has to wear a mask and social distance. Next slide, please. So I need to ask Jamie if we have time. I know we have gone over the allotted period of time. So I don't know if we're in a position to be able to talk a little bit, have a little bit of a discussion, take questions. So I didn't want to just move on to the next part without checking in.
Absolutely, we have plenty of time left.
Okay, Jocelyn, want to kick off our discussion?
Sure. I mean, and that's great. I'm really proud of us because we rarely have time left when we're done a presentation. So this is good news. Yeah, so, I'm actually seeing some of the chat, what some people are saying. And I think one thing we'd like to open up a discussion to is particularly these last two issues that we just spoke about, both visitation and also the self-determination, but really the quality of life within the facility, and to hear what you guys are hearing about this, because all of these other rights, I mean, they are all crucial, but I think at the end of the day, they all really do speak to and get out, making sure people have the highest quality of life that they can. And what, Robyn was just talking about with residents, still confined to their rooms, with residents unable to interact with each other, unable to see visitors when they want. This is, it's just, these other things are just, almost less important when the quality of someone's life has deteriorated like this. So we're really interested in hearing from you because, as Robyn said, the guidance says that these things should be happening now. People should be able to eat with their friends. They should be able to see their friends in the facility. They should be able to leave the facility. And so I think we'd like to maybe just open this up, if we can, to a discussion with everyone, where people can sort of just offer what they're seeing and hearing. I don't know how that works. If we could maybe, I guess, pull down the PowerPoint, and I don't know if normally discussions are just facilitated by people just speaking or raising their hands, or how it works, but
Jocelyn, it's Jay here. I have a couple of the questions that came into chat that should give us a good start, or comments actually. Brian Sewell makes a very good point that because visitation isn't fully reestablished, a lot of speculation and assumptions have to be made regarding the level of care residents are receiving. And a full visitation provided an additional layer of oversight in which the facility now lacks, especially during off shifts.
Yeah, I mean, that's a really good point, and it is very true. And in so many ways, and even what I was talking about earlier with antipsychotic drugs being prescribed, without visitors being able to be in facilities and have their eyes on things, it's hard to know what's really happening. And in fact, earlier today, we were on a call, Robyn and I, with state ombudsmen, and we were asking them specifically some of these questions about what they're hearing about whether or not residents are able to engage in communal dining. And they're starting to find out, but even ombudsmen are re-entering facilities now. They haven't been in facilities over the past year in the same way they were before. So you're exactly right. Visitation is so important because it puts extra eyes on everything that's happening. And without it, it's really hard to know the kind of care that people are receiving.
And here,
and I would just, I would just add that Jocelyn talked about a resident survey we did, but we did a family survey earlier and asked families. This was when visitation was opened up just a little bit, sort of toward the end of last summer. And what we heard were just terrible stories, examples of care that hadn't been provided, residents who hadn't had personal hygiene, hadn't had their hair washed, hadn't had oral health care done for a long time, residents who had really declined in their ability to perform, to walk, to sit up, to feed themselves, and real mental and psychological decline as well. So that visitation from family members is absolutely critical. I think we always knew how important that was, but if anybody doubted it at all, I mean, this has just underscored how incredibly important family visitation is, and oversight, having the ombudsman in there, having the Department of Health actually in there conducting investigations and annual surveys. So absolutely an excellent point.
I think another very good point brought up here by an anonymous poster is that families and residents need to be interviewed by surveyors. The families are in the trenches and they see firsthand what goes on inside.
Absolutely. And in fact, they are supposed to be interviewed as part of, certainly as part of the regular inspection process. It does call for residents and families to be interviewed. If they go in on a specific complaint example, they're supposed to be talking to the family member filed the complaint, to the family member, to the resident. Now, we don't always know how well that happens. So I would say, and just encourage all of you, if the surveyors are in the building, ask to talk to them. If that's what you want to share, what you have observed in your loved one's experiences, you can always ask for an interview.
So I just want to say, I saw someone just write in the chat, they asked if visits are now allowed in the room. They're saying that, only 2 families are allowed in a time, I guess, in their facility in approved space. The guidance doesn't say that you can't have in-room visitation. I think this is really important because what I was saying earlier, for some people, we know that having 1 hour twice a week is huge. I mean, that makes a big difference. But for people who really want to be able to help their loved ones, for people whose loved ones who, as Robyn was just talking about, have declined dramatically over the past year. I mean, we have talked to people whose loved ones have lost 40 pounds. They need someone in there to make sure they're eating. I mean, they need more visitation. What the guidance says is that if residents share a room, then if possible, the visit shouldn't be conducted in the room. But for situations where the health status of the resident prevents them from leaving, they should try to enable the in-room visitation while adhering to infection prevention principles. And so what we have told people is that if you have a loved one in a facility who has declined or who is in a position where maybe they can physically get out of bed and into another area of the facility, but if their current status means that in-room visitation would be much more beneficial to them, then you argue that it's not possible to have the visit somewhere else, that you need to be in the room. So I saw that, and I just wanted to emphasize that facilities should not just flat out be denying in-room visitation. They should be allowing it when it needs to happen. And in some of these cases, it absolutely needs to be happening.
Thank you, Jocelyn.
Sure.
I'd like to back up a little bit to some of the earlier questions here, because especially of interest to a lot of people here is Sheldon Schwartz asked, at some point, please discuss the difference between the skilled nursing facility requirements and the personal care home requirements as far as resident rights go. What's the difference?
So I'm going to punt that back at you, Jay, or back at the Ombudsman Program, because we don't know what the assisted living regs are in Pennsylvania. So the thing about assisted living is it's not, there are no national standards and requirements the way there are with skilled nursing facilities. So it's state by state, and every state is different. So you can have one set of rights in Pennsylvania and another over in Ohio. So, and I'm not just trying to get out of answering this question, really need to have your help with this one. Certainly the one thing I will say is there tend to be fewer rights in assisted living than in nursing homes. So with that, who wants to take it?
I'll jump in on this one, Robyn. We're pretty unique in Pennsylvania because we have two separate additional licensures. So we have personal care home, and then assisted livings are licensed as their own. So we have two other sets.
Even more complicated, okay.
Absolutely. So that's something that we can tackle in a future meeting, more specific to personal care and then assisted living. If that's something that the families would like, we could definitely do that.
I will say that's an excellent question, because I think, you read in the media, they seem to get nursing homes and assisted living mixed up. And so it really is important to know that they're different. The requirements are different. The care they provide is different. So good question.
Well, here's a question that Gloria and I are going to jump in before you two get to it. Who are mandatory reporters? And ombudsmen are not mandated reporters. We're prohibited from reporting or disclosing information that a resident does not want to be disclosed. So now, who is the mandatory reporter?
So the nursing home is a mandatory reporter. So I'm just speaking under the federal regs, which says that the facility is responsible for reporting, and if there's a suspicion of a crime, it's actually the individual who has knowledge of that is required to report. That's what the regs say, the federal regs, but often in states, mandated reporters are, hospitals. When somebody goes to the ER, for example, or comes in, hospitals are, social workers are. I'm going to punt this now to you guys for other individuals in Pennsylvania that are required to report.
I know that we get phone calls and many skilled nursing facilities don't understand that we are not the ones that are supposed to call. And
Yeah.
I tell them, call OAPS, call Protective Services.
I'm really glad you raised that point, Jay, because it's very important that the reason for that is because when residents speak to the ombudsman, that information is confidential and private and can only be disclosed if the resident gives permission. That is the basis of the trust and building a relationship between the resident and the ombudsman. If you don't have that trust, a resident is not going to tell you what his or her concerns are and the problems are. So that's the reason. If a resident tells you something in what they think is confidence, but the ombudsman is a mandated reporter and then turns around and it doesn't matter what the resident wants and reports it, that relationship is gone. It's totally destroyed, and that resident will not turn to the ombudsman no matter what is they're experiencing at that point. And the whole basis, so it's so
Robyn,
important.
if I may, there's one other
Please.
point I think, and that is we are advocates for the residents. We're not policemen. And I think that also is a very important point, that we're there to advocate. That's why we're not mandatory reporters, as the policemen are and the protective services are. We're there to advocate for the residents. So that's the reason for the confidentiality, and we're there to advocate for them. I just want to make that point.
No, I'm very glad, Sheldon, that you made that point. And you're not the inspectors or the surveyors that come from the Department of Health. You're not regulators, right? As you said, you are advocates. So that is why ombudsmen cannot, are not mandatory, cannot report abuse and neglect unless they have the permission of the resident.
This sort of leads into Brian Sewell's question of what legal outside entity is responsible for holding the nursing homes accountable to the items discussed here today. And the Department of Health is the regulatory agency that oversees skilled nursing facilities. However, personal care homes and assisted living are overseen by the Department of Human Services.
Okay.
Maggie Horn asks, just confirming that when you say the resident has the right to, does that mean the medical POA would have the right?
If the resident does not have capacity in general, that's when the ability to exercise those rights would go to actually the word in the federal regulations is the resident representative, and that representative is defined as being, it could be a guardian, it could be a medical power of attorney, it could be someone that the resident just wants to be the person who helps them make decisions and makes decisions on their behalf.
Please clarify what can't meet resident needs means. This person's family has complained and been very vocal about short staffing and substandard nursing care where her 88-year-old father is a resident. They want to know, could the nursing facility use this against her dad as a reason to discharge him?
The facility could go that direction. We sometimes see a facility that doesn't have enough staff say that they can't meet a resident's needs. So several things you have to know. One is that they're actually required to have the staff that is needed to meet the resident's needs. So saying they don't have staff is not acceptable. And when you say you can't meet the resident's needs, that means really that the resident doesn't need nursing home care. That's when you can't meet the resident's needs. It's truly when a resident needs, say, hospital care or something like that. But if they are able to, what they need is nursing home care, then a facility is required to provide all the services a facility needs. Resident needs, sorry. That being said, the reality is we do see facilities that maybe they feel like a family member is being too demanding, by saying, well, but you're supposed to have enough staff, right? And they may issue a notice of transfer discharge. And that's where it's really important to know that you can file that appeal. Because in that situation, that would be an instance where you would really want to file an appeal and have somebody, help you make the case for the fact of that, and to point out what the facility's obligations are. Because often they sort of go to the easiest path, right? The easiest route is to say, we can't meet your needs. And it often, underneath it is, the family's too demanding, they're complaining too much. There's often something else going on that gets hidden by we can't meet their needs. So I will just say, if before any written notice is ever given, if a facility says to you, we're concerned that we might not be, your mother might not be getting the care she needs here, that is a huge red flag, and I'd be calling the ombudsman at that point, because that means that they are starting down the path of saying, we really think she would be better off elsewhere, we'd be happier elsewhere. So long-winded answer, but that's why those protections are so important.
Robyn and Jocelyn, I just have one other question from the chat, and then we can open it up to the floor. Maggie would like you to speak about the rights for outings, social and medical, during a shutdown due to a staff member testing positive.
This is always the hardest question.
Take a first stab at it.
Sure. Well, it brings up a couple different things. To start with, so within the CMS visitation guidance, outbreaks are their own section, and it talks about the definition of an outbreak is, and as you remember, I mentioned an outbreak is one time when visitation can shut down. An outbreak is any time a resident or a staff tests positive. And at that point, what happens is the facility temporarily pauses visitation in order to test everybody, to do outbreak testing and make sure that everybody goes through that testing. And then if they find that this is spread to people in other parts of the facility, and they use, I think, the term areas in the guidance, which is not a scientific term, then they will shut down visitation for 2 weeks because they consider this an outbreak. If no one else tests positive, or the only other positive tests occur in the same area as that first positive case, then they're supposed to shut that area down of the facility and keep the rest of the facility open. So the question becomes, what happens if one staff member tests positive? And we know this is particularly concerning to families. We know it's happening, and we know that there are many, not many, but we know that there are many more residents who are vaccinated than staff members right now. There's still a much higher percentage of residents. So it can be very frustrating when all the residents in a facility are vaccinated and protected from the virus, and you have staff who could potentially still bring it in or start this outbreak, which could then shut down visitation. From our understanding, from what CMS has said, if one staff member tests positive and they close down to do this outbreak testing and no one else in the facility tests positive, then the facility should reopen, because the assumption is that one staff member has left the facility. They are at home quarantining, hopefully, and then visitation can reopen because they've done, and that would mean that you can leave the facility and you can come back in and you can do all of those things again, because the outbreak is not, there's no outbreak. They tested, there's no one there, there's no one in the facility with COVID because the staff member is removed from the situation. So that's the way we understand what would happen if there's one staff member who tests positive. The whole facility should not remain shut down for a full 2 weeks unless there are more positive tests. So the second half of that is, you know, what about when people leave the facility? If you want to leave the facility, I mean, that outside of the outbreak context, the CDC has come out with updated guidance that says that if someone leaves the facility, whether or not they are vaccinated for less than 24 hours, so if you go to a medical appointment or if you go to have lunch with a friend or to see your family and you're gone for less than 24 hours, then regardless of whether or not you are vaccinated, if you do not have close contact with someone with COVID, which means you're not within 6 feet for more than 15 minutes with someone who is positive with COVID-19, then you should not have to quarantine when you come back to the facility. We know that's one reason some people have been afraid to go to medical appointments because they're scared they'll come back and be forced to quarantine, but that should not be happening. So, you know, I mean, I kind of separated those two things out. I'll just add that, you know, if you leave the facility for more than 24 hours and you are not vaccinated, then there is a quarantine requirement, which also exists if you were newly admitted to a facility and you are not vaccinated. In those cases, they can still require quarantining. If you are not vaccinated and if you have not actually had COVID in the past 90 days, I think it is, Robyn. If you've had COVID in the past 90 days, you also do not need to quarantine. But in terms of leaving the facility, I mean, this is really important right now. And this is very much tied up with visitation and with residents' rights to really live the kind of life that they want to live and their self-determination. You should be able to leave your facility. You have that right. I mean, a facility is not a prison, it is your home. So you should be able to leave and you should be able to come back. And just like anybody else, if you're not exposed to someone with COVID, there should be no ramifications of that decision. You should be able to leave and come back. And that's it. Continue about your business.
We're leaving this to hands.
Sorry, go ahead.
Go ahead, Robyn.
No, I was just saying that there is a lot of misunderstanding and misinformation on the part of facilities out there. So one of the things that we strongly recommend, and we can send the links to Jamie and Jay, is to actually get your hands on the guidance. I mean, we actually recommend that you print it off and highlight the part that supports, you know, what the position is, what it's supposed to be, and take that in with you. I mean, we have heard of families that, you know, have been told, well, we have to quarantine your loved one, and they point out, you know, they show them the guidance, and they've been able to get it resolved. So that guidance is a real tool.
Yeah, and I'll add to that. I actually talked to somebody a couple months ago, actually, who was in that situation where there was one positive staff member and their facility was going to shut down for 2 weeks, and they emailed us, and, you know, we basically told them exactly what I just said to you. And I said, take the guidance with you, show them what the guidance says. And they did that, and the facility opened, and they said the facility didn't realize this. You know, thank you so much for telling us. They're so happy to know this. So, I mean, I think it's really difficult to imagine that facilities have very limited understanding of all of this, but I just think there is a lot of information out there. And again, the quarantine guidance is coming from the CDC, not CMS. So if you look at the CMS guidance, you wouldn't see anything about what happens when you leave and come to a facility. And it can be really hard to keep everything straight. So yes.
We'll be happy to, Jocelyn, help me remember. We'll send the links.
It's a person who logs discharge and transfer notices from skilled nursing facilities statewide. I can tell you that a lot of facilities don't understand what needs cannot be met means. Some of them equate it with a hospital transfer, which is not what it is.
You know, transfer discharge issues has like been the #1 complaint that ombudsman programs around the country have dealt with for like the past, I think it's 9 years. It is a real problem. And that's why it's so important that the ombudsman program's out there.
From here, folks, I'm leaving it to hands. If you have a question you have for Robyn or Jocelyn, use the raise hand feature and we will call on you.
I don't see any hands right now.
Not yet.
So can I, until there's a hand, or unless there's a hand, we would very much like to hear just anybody, your observations about or experiences about visitation in your loved one's facilities, or what you're seeing happen in terms of residents being able to visit with other residents in the facility, or leave their room, or eat in the dining room.
We do have one hand that was just raised. Brendan, you can go ahead.
Yes. Does a resident have the right to declare treatment from an unvaccinated staff member?
To decline treatment?
From an unvaccinated staff member?
That is a very interesting question. I will say that, I mean, there hasn't been anything in terms of guidance about that. I would think that a resident could speak up and say that they would rather, would like to be treated by somebody else. That being said, staff are being told that all staff should be wearing masks at all times. So that my guess is that maybe that might be the response that you get back, is that all staff have to continue to exercise infection prevention and control measures. So so the resident should be okay. I think it's worth asking. Not quite sure where that would go. Jocelyn, do you have anything to add to that? It's a tough one.
No, I mean, when I think about it, I'm thinking, you can try to, I just don't know if you were to decline treatment, someone else would come and help you. I imagine the scenario would play out where you say you want someone else and their response is, I'm the only person who's coming. So if you want the treatment, that's it. And I will say, I mean, you're right in terms of wearing the PPE and taking preventative measures. I mean, we talked to someone many months ago, and sort of before vaccines even, in the height of the pandemic, a resident who was saying, like, when staff tried to come into her room without a mask, she would say, get out of my room. Do not come in here without a mask. So that is certainly something that can be asserted. If somebody tries to come in and you don't think that they don't feel COVID safe to you, then I think, you absolutely can, ask that they wear proper PPE, that those things are being done. But yeah, it's a really good question, but I think it is true. I mean, right now as a country, we are not requiring vaccines in most places yet. And so I think that as long as they have proper PPE on, I can imagine that it would be difficult, especially because so many facilities remain short-staffed. It might just be a decision that a resident would have to make, not knowing when they would then get that treatment from someone else or what that would look like.
That's a very, very good question. So I would, I think I would go down the path of asking and then see where it goes. But I think it's worth asking. I think Sheldon has his real hand up.
I can't raise my hand. I'm sorry. I can't figure that out. Question is, with HIPAA and stuff like that, and in fact, I was at a facility just last Thursday, and 50% of the residents were vaccinated and 50% were not, and the same statistic for the staff. And the question always is, with HIPAA, how do you know? You can't really ask that question, can you? And say, it's a great question, Brendan. And the question is, can you ask that question and get a answer? I'm not sure you can.
I mean, I hear this all the time. I mean, HIPAA has been floating around, I feel like, as a defense everywhere these days in terms of the thing is, you can always ask someone. People can always offer up their own medical information if they want. And so
Right.
to me, my feeling is if someone's vaccinated, they're going to tell you. So if you ask and they don't want to answer, then I would assume that they're not vaccinated. I mean, but that's, not a scientific way to do it. But I think, if you have proof of a vaccine, you can show that proof of a vaccine. If you don't show it, then, people can make their own assumptions. But that's,
Jocelyn, that's a great answer. And that's the way it is now. You walk in stores and people are saying, if you are vaccinated, you don't have to wear a mask. Or were they
Right.
going to ask you,
Right.
challenge you?
Right.
No, you don't want to fight with the guy as he's coming in. So people say yes.
That's right.
It's going to be a learning experience in the new normal that we're moving into.
That's for sure.
All right. I don't see any other hands or new questions. So I would like to thank you ladies very much
Yeah,
for
good
sharing
job.
Thank
all that
you.
information.
Our pleasure. Thank you for asking us.
Yeah, absolutely.
We always love speaking with you all. You're a good group.
We love having you.
Oh, so yes, thank you for putting that up there. This is a handout that we have about residents' rights. These are the federal residents' rights for nursing homes. But the next slide will give you the link to this. So which one is it? It's the second item up there is the link to that fact sheet. And then we've also given you a link to the actual regulations and then to some ombudsman information about residents' rights.
Fantastic. And we will make sure to get everybody these links in the follow-up email for tomorrow so that you can have that. And are we able to share your slides with the group?
Oh gosh, yes, absolutely.
All righty, we'll send those as well. Thank you so much again.
Thank
Okay.
you.
Thank you. You guys have a good rest of the night, and thanks for all that you're doing for your loved ones.
And I just
And
wanted to
thank you
take
to the Ombudsman Program. Yay.
Yes.
Thank you. I want to remind everybody that our Facebook chat area is available to family members only. If anybody hasn't had the opportunity to join that, we have over 250 family members participating. If you would like to join that, it is a group associated with our Facebook page. And I want to quickly review our upcoming meeting topics. So on June 15th, we have Protective Services. They're going to speak to us about what their role is and what they do for the elderly and nursing home residents as well. So that's on National Elder Abuse Awareness Day. So we have Denise Ketchen. She's the director of the Pennsylvania Protective Services chapter. So we're pretty excited to have her. And then on June 29th, we're going to have a discussion on what COVID exposed and where do we go next. So we're going to hear from Dr. Alice Bonner and Dr. Terry Fulmer. So we're pretty excited about what they have to say. And then on July, believe it or not, we're going into July. We're going to hear about assessments and care planning. That's going to be from Richard Malott. He's the executive director of Long-Term Care Community Coalition. So we're pretty excited. We got an awesome lineup coming up. And if anybody has any suggestions on topics they would like to see, send us an email. We would love to put some on the schedule for you. And as always, thank you for attending. If you have any specific concerns or complaints, please email the State Ombudsman Office at ltc-ombudsman@pa.gov or give Jay a call at 717-783-8975. Thank you, everyone, and have a great evening.